So good morning, everyone, and welcome to the Chair and Chief Executive's brief. Ordinarily, this will be a face-to-face meeting with the Chairman, Mike Moore, and myself, Roland Sinker, the Chief Executive. We attempted to do this as a teleconference this morning, but there were so many people on the call that the technology was not able to support the session. So we've decided to do this as a pre-recorded Chair Chief Executive's brief. So I'd like to thank everyone for taking the time to listen to what we're about to cover. Ordinarily at the Chair and Chief Executives session, at this time of year, we will be talking about the successes and areas to work on in the staff survey. We will be talking about areas of really strong performance in quality and areas of anxiety. We'll be talking about meeting our financial plan for the year. We'd be talking about where we are on access target performance and improvement. And we would have been sharing the very advanced work we put in place around the building of the Children's Hospital and Addenbrooke's 3. But clearly today, we're going to focus the entire session on coronavirus, COVID-19, where we are nationally, where we are as an organisation, and the plan ahead. So, as we move on to COVID and coronavirus, I would start by saying I think we all recognise the profound sense of anxiety that many staff members are feeling as we look at what is happening internationally and nationally. And I think it would be fair to say that that sense of anxiety in many places is a quite strong sense of fear. People are afraid of what is coming towards the organisation, what that is going to mean for our patients, what it's going to mean for staff, colleagues, and what it's going to mean for people's family members. And I would be very clear and direct that that is an entirely understandable way to feel. And you should not feel anything other than normal in feeling those emotions. The second point I'd make is that the position is changing hourly, internationally, nationally, and in terms of what's going on in the region and here at CUH. And we're looking to respond to that position with that degree of flexibility and courage. So where are we as an organisation? Firstly, we now have a good understanding of where the organisation is at any particular point in the day. That comes through 9 a.m. meetings, it comes through our gold, silver, bronze infrastructure, it comes through regular updates to management, executive and the board. And as part of that diagnostic, we have a good understanding of what we should expect within the next 5 to 10 days and what we should expect in terms of the next 6 weeks and 12 weeks. We have a model that is trying to set out the level of demand, the level of care we're going to have to provide to enable us to do the best possible job we can for the population. Beyond the diagnostic, what we have now is a strengthening alignment of plans being developed from the front line through colleagues in, for example, the infectious diseases and respiratory teams from their lived experience on the front line, docking into the work that you've all been contributing to in our gold, silver and bronze infrastructure, docking into the 5+5 task forces that were set out in the Chief Executive's letter from Friday. And we're looking to align those different bits of planning over the course of the next 24 hours. So from that, we now have a much clearer strategy of what we're trying to do. And really, there are two elements to this strategy. The first is to enable us to look after the largest number of patients possible, both coronavirus patients, but also other patients with either emergency needs or very urgent needs. And secondly, to make sure that we are putting staff safety and well-being at the absolute heart of what we're trying to do as an organisation. Beyond that, the strategy is to see how can CUH and the Cambridge Biomedical Campus really bring all of its excellence, expertise, talent and experience to bear to enable us to lead in terms of what we're trying to provide as an organisation. So the task forces, I think, were set out very clearly in the Chief Executive's letter from Friday. They cover areas like staff safety and well-being and availability. They cover how we organise the hospital and indeed the campus to be able to provide the best possible care. They include how do we access the greatest number of ventilators to provide critical care capacity. They include terrific work around supply chain, making sure we've got enough PPE, personal protective equipment. And they include the work that we need to do to have the fastest possible testing for patients so we can get them into the right part of the hospital, and for staff so we know where staff are, staff can be back at work if that's appropriate, and staff know what their position is. There are then another 5 task forces relating to a range of areas which I won't cover now. Okay. So what I'm now going to do is to move on from that introduction, and we have a very large number of questions divided into a series of themes. And what I will do is I will read out the questions and then I will hand to colleagues who are with me to provide an answer. So, in terms of the first area, personal protective equipment and procurement, Ian Hooper will be answering the 2 questions. So, the first question is why, if the supply of PPE is not short, are we experiencing problems with it on the front line and it's almost being rationed? Ian.
Okay, thank you, Roland. Okay, up until last week, central stocks of PPE were being controlled nationally. Therefore, not all orders were being fulfilled. As of the end of last week, we were advised the national restrictions have lifted, and therefore we should begin to see outstanding orders being satisfied from this week. As a result, we are increasing our holding order levels from today, and we expect these supplies to be accelerating from this point forward.
Thank you, Ian. And then the second question for you, Ian, is the procurement department accessing personal protective equipment from non-medical suppliers, for example, FFP3 masks and visors that one might be able to take from agricultural suppliers or paint spray suppliers, for example?
Okay, so the answer is not currently. However, we are exploring such options as resilience should the national supply fail to meet our requirements. In addition, we have set up a process for receiving PPE donations in collaboration with Addenbrooke's Charitable Trust and Cambridge University. At this stage, we don't see a need to source alternative products unless things change over the coming weeks.
Thank you very much, Ian. Okay, could I now come on to staff testing? And I'm going to ask Nick Brown and Giles Wright in some combination to answer these questions. So, first question, are there plans to start testing staff for COVID-19 to avoid unnecessary self-isolation? Nick.
And the answer to that is nationally, yes. And there are preliminary work already underway nationally to facilitate this with large escalation of capacity for testing. So at the moment in this hospital we are doing something like 400 tests per day for not just this hospital but others in the region as well. And the ambition nationally is to increase this to some 50,000 tests per day, a massive increase. And that will take resources from non-NHS laboratories so that the access to testing can be massively escalated. We're also looking at commercial tests as they become available, but that is likely to be in the slightly longer term in a matter of weeks. However, there's a caveat to this in that that testing isn't available at the moment, and therefore we are hesitant to say everybody should be tested now, because that will mean that we won't necessarily be able to do all the patient testing that we need to do, and that is our number one priority, particularly those patients on critical care unit. And I'm sure Giles would like to add something to that as well.
Thanks, Nick. Yeah, so just to give assurance that we are actively preparing an approach to staff testing as and when that comes online. So we are considering that carefully now so that we've got a clear process and strategic approach to it so that we're ready when it's switched on.
Great. So thank you very much, Nick and Giles. There was a second question on staff testing, which I think you may have covered. And I'll just ask it and see if there's anything you'd like to add. Are there plans to test medical personnel who have been exposed to patients with confirmed COVID-19, specifically when the exposure was prior to their positive test result?
So I think that's part of our preparation and approach to staff testing. As and when that's turned on, we will look at staff groups and those that need the testing as priority.
Okay, thank you very much. I'm now going to move on to the fourth area of questioning, and that relates to infection control. And Nick, Rachel, and Jonathan will be commenting on these. So the first question is, when will visiting be stopped completely? So Jonathan, yeah.
I just wonder if it might be appropriate to give a bit of an overview of the kind of experiences that people are having in the organisation, and then think how it links to some of these questions. So at the moment, we have patients who have very limited access to visitors, and we're already learning about the impact upon them in their experiences in the hospital. The experiences for patients are already changing, and we're noticing that. The second thing is, so many of us are leading such an odd existence. We have this incredibly social, busy, draining life at work, and everyone else in our lives is doing the complete opposite. So there's a number of things going on that are leading to some quite stark juxtapositions. There is being worked up a campus-based plan around safe working and segregation, and there are so many issues to consider. One is visiting, one is the use of the concourse, one is how teams work. How do those teams that usually all used to work together on a day work with COVID and non-COVID? How do we provide showering facilities so that they're not mixed, so that people who haven't worked with COVID can shower in one area of the hospital and people who have worked with COVID can shower in another? What about social areas and the way we interact in a way that's safe? So I think the proposal is that there'll be a kind of campus-wide view on this that we expect to be able to review tomorrow, and a lot more information later in the week.
Great. Jonathan, thank you very much for that. Second question, once capacity for testing has improved, should we swab all patients being admitted? So Nick.
For the foreseeable future, the answer to that is no. The principles for testing should be the same as with any pathology investigation, that you should only test patients who are likely to have the condition that you're testing for. Otherwise, you increase the likelihood of getting a frankly misleading result. However, many people would have seen on the news that there are antibody tests that are will be available fairly soon. And they will answer a different question, which is, has someone had it? And it is likely that they will be used for epidemiological purposes as well as for clinical management purposes in the longer term, but this is not for now.
Nick, thank you for that. And then the last question on infection control. Lots of us don't seem to be socially isolating. There is a mass queue for Costa Coffee. There are meetings in small rooms, and people are being invited to attend meetings. It's personal behaviour, but it's supported by organisational behaviour. What is the advice to staff in these situations? Now on that, I think what I would do is refer back to the comments we heard from Jonathan a moment ago, which is the guidance that's coming out around meetings and how we would like people to behave. Okay, good. Thank you then. So if we move on from the fourth area to the fifth, which has got a lot of different subparts, and that's around workforce. And Ansley and Giles are going to help us through this. So first of all, on pay, can staff be offered overtime as opposed to working bank shifts, as many will be penalised for having a second job? Ansley.
Okay, so the reason we are working through the bank is because it gives us centralised management of where we deploy staff and where we have need and where we have available staff. It's well established and we've got good processes in place. Obviously we review the situation daily in terms of staffing and we're looking at that constantly, but at the moment it's via bank.
Great, thank you Ansley. And then Ansley, are there plans for enhanced pay rates for staff working in COVID wards, suspected or positive?
Again, we review staffing daily. It's very, very important that we do, and we will respond according to trust need and capacity requirements. It's something that we do routinely anyway, so we'll be building on existing processes to make sure that we're constantly reviewing that.
Lovely, thank you. Then a series of questions around redeployment. So first question, will some of those working from home be asked to come back to site to undertake duties? For example, to porter, answer phones, or to feed patients?
So simply put, yes, we are encouraging staff to work from home where it is possible, but on the clear proviso that as and when they are required to come back in, if there is a need for them to undertake duties on site where possible, we'll bring them back in.
Is there a list, sorry, next question, Ansley. Is there a list or assessment of staff skills and prior experience? Who will and or would hold that?
So we have put a process in place to centrally gather that information and record it. Many people have come forwards and offered that. It will be held by workforce, and we will then we're using a matching process which is in place now, where we identify the need and then we match it with those skills that we've got identified. So that's an ongoing process for us.
Right. Thank you. Then next question, will surgeons or medical staff be redeployed?
Possible and likely that yes, they will be needed to be redeployed, and that will be managed through medical staffing with the medical teams.
Lovely. Thank you. What are the plans to provide training to redeployed staff?
Okay, I think it's really important we make clear nobody will be asked to do work that they are not skilled or capable of doing, so therefore training will be in place. We've got training listed on DOT, which is about reorientating people who've perhaps been out of clinical practice for a while, but also training to support people who are perhaps going to undertake different roles. So yes, training will be provided, as will induction to new areas, and if there are any requirements around safety. So absolutely yes, but to reiterate, people will not be asked to do work that they are not competent in doing.
Great. And then the next question, which I think you've answered, are there any competencies or reintroductions for staff that they could be doing now if they were to move to areas?
It's out there on DOT, so please log into DOT and book on if you think you're going to be moved.
Great. When will redeployment happen? I've attended update training and I'm keen to help, but I haven't heard anything.
Okay, so it's happening now. We're collating a list of people. We have those lists already as they're building, and people are being asked to move. So we will be in contact with you as and when you are required to be redeployed.
Then there are two final questions, Ansley, on redeployment. So the first would be, will colleagues from the same speciality be kept together when redeployed to keep morale up?
So the important thing is we get the right people in the right place to support the organisation, patients and colleagues. Therefore, the priority is to make sure that we've got those skilled people moving to where they're needed.
Great. And then lastly, will you be sending staff to help the private hospitals? Ansley, and then Jonathan, if you want to comment on redeployment, that'd be lovely.
So that hasn't been a request of us as yet. Obviously, we are taking a system-wide view and working with partners to make sure that we are supporting the system as well as ourselves. I have to be honest and say at the moment our priorities are making sure that we have the staff here.
Right, okay. So Ansley, thanks for that on redeployment. Jonathan, you wanted to come in on redeployment briefly, I think.
And it really links to working from home. It's such an extraordinary situation that you have a high proportion of your workforce who are physically well at home. And it means that, and also we have such opportunity to change the way we think about our daily roles. To give you some examples, in some of the teams I work with, they have done everything they can to reduce the emotional toil to people who are actually in work at the time. So I think a very sensible thing that you need to do within each team is to look at every single duty that comes up in different roles and understand what could be done with a home working team. If you're lucky enough to have BYOD, you have complete access to the trust infrastructure. So for example, doctors can now do the on-call when they're home isolating to allow those who are on the wards to get more rest. And I think there are really smart things that can come from this.
Right. So Jonathan, thank you for that as an overarching comment around home working, which I think is a very good build on redeployment. There is then one additional specific question on working from home, Ansley. So, should all administrative staff work from home if they're able to? The guidelines for admin are not clear, and some staff feel pressure to come on site even though their work could be carried out from home.
Okay, so following government guidance last week, we made it clear that all managers should be talking with colleagues to encourage home working and facilitate that where it's possible, so where work allows it and where people have the opportunity and equipment to do that. We have put some principles around that, but I think it supports what Jonathan has just said. We want people to work from home where possible. It doesn't mean we might need to bring them in as we redeploy people around the organisation, but please, if you can, work from home.
Great. Thank you, Ansley. Ansley, there are more questions for you, but you're doing an absolutely superb job, so we'll keep going. So next is on staffing levels and self-isolation. So how will we manage the shortage of staff caused by the self-isolation period?
Okay, so we've already talked about redeployment of staff and people volunteering to go into other roles, people being asked to move around. We're also increasing our bank membership, so we've been in a very fortunate position that last week we went out internally asking people who already work in the organisation if they could offer additional shifts. We've been overwhelmed by the response, and we're uploading about 70 people a day who haven't previously been registered. We also went out externally to members of the public asking for people to come forwards if they had previous experience of working in care. And again, over the weekend, we had nearly 300 enquiries of people wanting to join the bank. So to those of you that are out working today, feeling anxious, that there are more people coming. There are people who want to come and help you.
Thank you. And then Ansley, how is the need for a staff member to self-isolate being validated?
I want ask Giles to respond to this. Thank you.
So as a population of 11,000 people, each from our own communities, we are following suit with the national guidance. So essentially, isolation is broken into two categories. So one is if you are symptomatic as an individual with a persistent new cough and or a high temperature, that you isolate for 7 days. If a member of your household becomes symptomatic, then you isolate for 14 days, and we're staying with that for the time being. In terms of validating that, so we're symptoms led. I think I'd bring us back to our trust values of kind, safe and excellent, and it is essential that we trust all of our staff to do the right thing, particularly at this time. So if somebody's feeling they need to be isolating for one of those two reasons, we trust that that's the right thing to do, and we support them in that.
Great. Thank you very much, Giles. Next on to risk assessment. Why are orange risk category staff members still expected to come into the hospital?
Thank you. So I guess the first thing to say is that we have, throughout the last 3 weeks, had a dynamic risk assessment model in place. We were ahead of the game compared to some organisations in the country, and we've absolutely mirrored the national guidance and been led by the expertise. That expertise and guidance continues to develop as we get evidence and data sets nationally, and indeed over the weekend some of those at-risk groups and Royal Colleges that support those patients have provided more for us to reflect on and build into our next version of our risk assessment. Specifically to staff that are in the orange risk categories and have those conditions, although there is an increased risk to the effects of COVID-19 for you, it is deemed perfectly sensible and sound that with control measures put in place and an individual risk assessment based on your needs and your history and circumstances, the risk of the effects of COVID-19 can be mitigated and well managed. The occupational health team has supported individuals. We've had over 3,000 calls in the last 2.5 weeks, and we will continue to be your source of advice in this time.
Thank you. Next question. When will the volunteers be asked to leave the hospital, as they're mainly in the at-risk groups?
Okay, so every volunteer has been written to and provided with a copy of the self-assessment risk form, and I think people will have noticed that a large group of volunteers are no longer coming on site. At the moment, the national advice is that volunteers can still come on, but again, we're reviewing this daily and we will take action as appropriate.
Right, thank you. So now 2 questions on morale and senior visibility. So what other steps will the Trust take to keep up morale during this period?
So I think the first response is that, as Roland's already mentioned and referenced, anxiety levels are going to be present in our workforce as they are across the country. We've all got a duty to respond to this and to keep morale up as best as we can. When we're under increased stress and pressures, our ability to listen to one another gets strained, our words and conversation is under pressure as well. So we just all need to be aware of our own responses to the anxiety and to the stress levels. We are going to implement as a trust other ways that we can help to support staff and to best support morale.
Okay, so just looking at that practically, we can put things in place and are doing so that will help people who are having to come on site and also working from home, just to make their life hopefully a little bit easier, and that's around providing drop-in space for people to get some food, some rest, supporting better access on site, so people bringing their cars into site, supporting where public transport is diminishing, but also providing psychological support, listening services and counselling as and when it's required. So making sure that offer is very, very clear to staff across the organisation, and we're building that up. We're building the staff sanctuary, so that's a repurpose of the Frank Lee Centre to be a space for staff to get some time out, get some food refreshment. We will also making sure that we've got that coming into places as well, so we're outreaching where people can't get off wards.
Great. So thank you for that, Ansley. Next question, when will Gold Command attend meetings and be seen?
Okay, so Gold Command is a structured part of our response to COVID-19. We have people on site daily on a rota basis. They are available, they're meeting. It may not be physically be seen, because I think we're all trying to self-isolate. They're on site, but it's about communicating in ways like this and making sure that very clear messaging comes from Gold Command.
Yes, I think that's a very good answer, Ansley, and I think there are two very strong underlying themes here. So one is the leadership of the organisation cited on the challenges that our colleagues are facing in terms of providing care, the anxiety or fear they're feeling for themselves and for their families and for their colleagues. And I would have thought from these questions and the mechanisms that you will know are in place, the answer to that is definitely yes. In terms of visibility of senior leadership, we are working very closely with the communications team to find mechanisms, of which this is one, to get the messages that are coming up through the organisation and what the organisation is doing about it out into the trust. Okay, I'm going to come on now to accommodation. Is there accommodation available for staff to use, potentially for a longer period, for example, weeks as opposed to days? Would there be a cost, and who do we contact?
Okay, so we have set up accommodation to be available. The contact details for that is an email address, which is accommodation@adambrooks. If you need to fill in a simple proforma that just states why you need the accommodation. It is available for people who need to come on site and need to maybe either self-isolate or need to be here away from family, whatever. Just put the reasons why you need it down on the application form. There will not be a cost. It is funded by the trust. We review this fortnightly, so there is a view that we may be able to offer longer term accommodation as required.
Right. Ansley, that was a fantastic job answering a lot of questions with Giles. Well done. We're now going to come on to, I think, almost the last section, which is on estates. And Karen, great to see you. So first question, Karen, for you. Can the shops on the concourse be closed for public access to avoid people congregating, and the M&S, the Marks and Spencers, remain open for staff only?
Thank you. I think this links to the point that Jonathan made earlier about how we behave. And currently people are coming on site that are not staff, and there are no other facilities, so we do have an obligation to provide some services. But what we are doing is being more attuned to people coming into the hospital to stockpile, so that's what we're doing. A number of shops opening times have been reduced, and there's some communication coming out regularly about that, and some outlets have already closed. In addition, seating has been rearranged to adhere to social distancing guidance, so that also helps with people not congregating.
Okay, thank you, Karen. Next one, are there plans to introduce free car parking for staff during this time?
The answer is yes. So we have had agreement with our 2 car parking operators to offer free car parking for staff to be reviewed at the end of April. So communication should be going out later to staff. So the message is, if you're already have access to park, just use your ID badge. If you don't, then you need to take a ticket and have it validated before you leave. But yes, the offer is there for all staff in all car parking areas across the trust, and that will be ready for
Great.
tomorrow.
Lovely. Thank you, Karen. Next question, can the Trust provide coffee, tea and potentially even food for staff on the wards to reduce the need for staff to go to public areas?
So the staff that are working in COVID positive areas already receive food and beverages as part of their patient catering service. So that's a support there. We are not currently providing coffee and tea on the ward areas, and I think that people should be encouraged to take a break whilst they can, and we will continue to keep this under review. We're also looking at ways of providing some access for staff to coffee and tea away from the clinical areas in the staff eating area, but more on that later.
Great. Lovely. So thank you, Karen. And then the very last question, and then I will sum up. So the last question is, looking forward to the future, a significant number of patients' RTT, referral to treatment durations, are going to be increased because of COVID-19, and there'll be many breaches of the 18-week target. How is the increase going to be shown on the NHS timeline on the grounds that COVID-19 is not patient or hospital initiated, it's a force majeure, it's an external event? So I'll answer this. So within the bounds of what is reasonable, all or nearly all core operating plan requirements have been, broadly speaking, suspended. But we have to, take that and interpret that with intelligence, which is what we're doing. So clearly, there are some elements of people's care that will need to be delayed and postponed. There'll be other areas, for example, urgent cancer or major trauma, where we would obviously continue to think about how we would provide that care. But there will be no penalty for the organisation as a result of missing operational targets as a result of COVID-19. Okay, good. So a huge thank you to the communications team for putting this session together, and to all the colleagues who've contributed. And I'll sum up on behalf of Mike Moore, the chairman, and I. Mike's with me now. So I think probably 4 overarching points. So I think the first point would be we all fully recognise the anxiety and fear many colleagues are experiencing as we start this week, and that is entirely understandable and should be absolutely respected. The second point I'd make is we have a robust diagnosis of what we are facing on a day-to-day basis, and we are working back from a plan that says how much capacity would we need for what community of patients in a way that would keep our staff safe and protected at what point. And we're thinking, when will we start to see an increase in patients with COVID-19 coming to the hospital? When would we reach a peak? And how long would that peak be sustained? And that's really in the 2-week, 6-week and 12-week time frame. The third point I'd make is that in response to that challenge, we have a clear strategy to look after and save as many people as we possibly can, both with COVID-19 and with other conditions. And absolutely central, how do we keep our staff feeling safe and actually safe? And then underneath that, the melding, the coming together of the bottom-up plans from our experts in the infectious diseases and respiratory teams, meeting the task forces that we've talked about a little today. And I hope that some of the answers you've had today give you a sense of the depth of work that's going on in all of those areas. The final 4th point I'd make is clearly this is an extraordinary challenge that we're facing. And in some areas we will be successful, and in other areas we will struggle. And we should recognise that our plan will struggle as it comes into contact with this condition, and that is no reflection on any individual and the enormous effort they're putting in. All we can do is our absolute best in the structure that we have. But I think in line with that challenge, we have the potential here at CUH and on the Cambridge Biomedical Campus to really lead the country in how we're providing care to this community and other patients. And I know that we will all continue to work extraordinarily hard to deliver that strategy and that vision. As ever, do email with any questions or comments. There'll be lots more comms as we go over the next week and the weeks after. Thank you all for your hard work. Well done. Keep going.